So my name is Rachel Jenner. I'm a consultant in emergency medicine. I work at Royal Manchester Children's Hospital, but I also have a role since last year as the clinical lead for the Greater Manchester Violence Reduction Unit. And I'll talk a little bit more about what that encompasses later. My colleague Kirsten McDermott, who's an advanced paramedic at North West Ambulance Services, sharing this presentation with me, and I'll let her introduce herself shortly. So if you've dialed in today to hear about the optimum ratios for blood transfusion in paediatric massive hemorrhage, I'm afraid it's the wrong session. We can talk about that on another occasion. But what I want to do today is really start provoking some thought about trauma, about injuries and violence, and start thinking about what could we do as frontline healthcare professionals to try and prevent this. How can we use our knowledge and experience to promote better health for our population and really reduce the incidence of serious violence. So some of the things we're going to cover, just going to have a little look at some of the data, some of the current trends in serious violence, but we're going to focus more on the drivers, what leads people to either be at the receiving end or be the perpetrator of serious violence, what kind of adverse childhood experiences may they have had, and what kind of traumatic experiences have they had growing up that's affected their behaviour and their life outcomes. We'll talk about trauma-informed practice, and this is a phrase that is very well known in many fields, in social work, in education, in child development, and this is talking about trauma in a different way to we as professionals who deal with the actual injuries. This is talking about traumatic experiences. It is a bit confusing that we use the same word to mean two different things, but I'm sure we can deal with that. I'd also like to cover violence reduction units, a little bit about how they've been evolving in the UK, and how you can get involved with violence reduction. And I think the most important part of this presentation is we're going to introduce you via videos to some of our frontline colleagues and hear their experiences and their thoughts on what they've been doing to try and affect violence in the UK. So there's lots of media coverage. Never a day goes by without some kind of news story about violence events. The BBC showed this a couple of years ago, the first 100 murder victims in the UK. And you can see that people of all ages, all ethnic backgrounds are affected by serious violence. More recent figures, if we're looking at the effects of lockdown, it does appear that during lockdown there's been a slight decrease in serious assault and in homicides, but unfortunately domestic violence has risen in that period. So the target and the focus may need to change as we respond to our constantly evolving world in the middle of the pandemic. This screenshot is another BBC series, and this is from the first 100. This shows the first 28 stabbing victims in the UK in 2019. And when we look at knife crime and the victims of knife crime, you can start to see a slightly different demographic from the group of people we saw before, with a preponderance of male, younger victims, and you'll see a disproportionate representation of some ethnic minorities and backgrounds. So this is the same data set. So in 2019, the first 100 fatal stabbings, it will come as no surprise to this audience that the vast majority of them are male, but also affects women, and it affects people of all ages, typically from the teenage years upwards. Knife crime is ever increasing. The only reason Greater Manchester is excluded from this data is that there were some technical issues with recording the data. Some slides I'll show you in a minute demonstrate that there's plenty of knife crime happening in Greater Manchester as well. But you can see that the trend is ever upwards. This one looks at episodes of hospital admissions as a result of knife crime. And again, there have been peaks and troughs, but we appear to be in a phase of increasing frequency of hospital admissions as a result of knife crime. That was national data. This is some data from Manchester, where I work. So we can see that there's an increase of violence over the past 5 years, but in particular on that slide on the right hand side, the grey area is assault with a sharp object, so seeing the increase in knife crime there. And if we look at all knife related crime, not just the ones causing injury, including offences of robbery, possession and violence, that doubles in Greater Manchester between 2015 and 2018. So that's pretty scary. Having said that, hospital admission for assault by bodily force, blunt force, punch-type injuries, punches and kicks, is much, much more common than knife injury. So while the headline-grabbing news can be stabbings and that type of assault, it's important that we don't forget all the harm and injury caused by non-sharp objects as well. And clearly, domestic violence overlaps with all these other categories. This data is from surveys done in schools in Greater Manchester, where knife crime was one of the number one worries for young people. When we look at the data, though, actually only 6% of the respondents thought that their friends carried weapons. So spin that on its head, we have got 94% of young people and teenagers who are not carrying knives. And I think it's really important that when we're talking to young people and talking to our communities, we promote messages of violence prevention, of safety, making sure people know how to deal with a penetrating injury if it happens, but actually promote the message that the vast majority of young people are going about their lives without carrying weapons, without resorting to serious violence. And we want to promote positive messages of young people and give them opportunities rather than work in a world of fear. In terms of the demographics, no surprise that both the majority of victims and perpetrators of violence are male, and the majority happen between people of similar ages. In the last few years, there's been an increase in crimes recorded involving teenage offenders and middle-aged victims, and we think that this isn't about young people going out and attacking older people in the streets. This is about familial violence. This is probably about teenagers assaulting their parents, and whether there's an actual increase or whether it's just being better recorded is difficult to know, but it's definitely more recorded assaults. Robbery is almost all male offenders and typically in the late teens. And if you look at the age profile of victims, there's a younger age prevalence for male victims and female victims, which again probably reflects domestic violence. No surprise again that women are much more likely to experience some sexual violence, domestic violence than men are. And when we looked at the data in Greater Manchester, we found that people of a BAME background were overrepresented in offender cohorts, so in perpetrators, and also in being victims of crime. So I think there are some inequalities and disproportionalities that we are seeking to understand. But there's an enormous overlap between victims and offenders. They're not separate groups. If you look at young people who are linked to crime, there are often small numbers of young people responsible for large numbers of crimes and taking up an enormous amount of resources. So in Greater Manchester, we have sort of 25% of children were actually responsible for over 50% of the crimes involving under 18s. And huge amounts of people are both victims of crime and suspects or perpetrators of crime. So it's not as simple as saying people are good or bad, people are innocent or guilty. It's a very complex scenario. And I'm going to hand over to Kirsten to talk a little bit about the adverse circumstances that can lead people into being both a victim or perpetrator of crime, and how we can use this to inform our practice.
Hi, I'm just going to share my screen shortly. When I get it. My name's Kirsten McDermott. Has that come up now on the screen? Yes. I'm an advanced paramedic working in Greater Manchester, and I have an interest in major trauma, work on the major trauma networks. And then I met with Rachel Jenner, and we were having discussions about violence reduction, and started working alongside her with this. And I came across this phrase of trauma-informed practice. It wasn't something that I had embedded in my practice prior to this. And I sort of looked into it a bit more, did some work with Greater Manchester Police, which who have embedded this into their practice. So I've got a couple of definitions. Is adversity and trauma-informed practice is obviously designed to work alongside all the safeguarding policies and procedures and measures already. And I really liked this bit about relationships matter, and every contact with someone who have experienced adversity and trauma can be an opportunity for healing and growth. I'd never really thought, actually, in my practice, when I'm going to these major traumas and dealing with the sort of stabbings and shootings, that actually I needed to be a lot more aware and sensitive to the wider context of the patient, the life. So I then looked into it, and actually we haven't embedded this into our practice, and we're looking at the 6 principles actually that we need to do to actually embed it into the paramedic profession, pre-hospital, but as well with the sort of the hospitals, the nursing and the doctors. So first principle is about being prepared. So we were looking at analysis on data, addressing priorities and the impact of ACEs, so your adverse childhood events. And as well, you're looking at whether that data should be collected on a national, smaller scale of GM, or even smaller clinical scales, to look at prevalence of patients with specific injuries. And then this can look at then influencing and presenting for the plans of the future and the present, and it can really sort of help with that. As well, you're looking then at local training for staff and actually change perceptions, and it can then help with the planning of resources and target services where appropriate. So not only sort of communities, but schools, hospitals, and as well, trying to change the thought processes, but actually going, what was wrong with you is actually what has led to this behavioural situation. So that's sort of being prepared, either within the profession or a service. Then you're looking at being aware. So obviously we do training, we do have an understanding of ACEs, we do have the safeguarding, but actually we need to look at symptoms and response to these ACEs, and understanding how young people, children in different sort of communities that can, how you can actually help them. So if you're looking to, and especially if they're continuing to live in adverse circumstances, whether and being exposed to poverty or gangs, and then actually using interventions that actually they will be appropriate for them and actually accessible for them. So we need to understand what they need. And as well, we need to look at what the associated symptoms are due to past experiences, and have a bit more of an understanding, and obviously more of a holistic approach. The next principle it was looking at being flexible. So we need to have a stepped approach. So whether it's at a clinical level or at a higher level, so you can access and engage people with such as street triage. But then looking at it, especially with COVID, we don't have that contact. We don't have the contact face to face or in schools or in the communities as much as we did previous. And actually, is there actually, have we been able to have that flexibility for people to actually access it? And then that flexibility actually then breaks down and should break down barriers, making it easier for healthcare professionals and other professionals to actually make referral pathways, have them accessible, and as well accessible for self-referral. So have a think about whether you can use looking at apps, online forms, as well as then involving feedback to actually then support decision making. So the next sort of principle that I was looking at then is actually looking for your service, whether it's got what policies, procedures, and actually is it trauma-informed practice? Is it embedded already? And as well have that support from knowledgeable, qualified people. And this makes it early intervention to avoid preventable exposure. And obviously having those policies in place, it then leads to sort of increased training. So it's as well being safe and responsible, not only for the children and the sort of adolescents that we may be involved in, but also as well for the staff. Because actually what can happen is that being exposed to these traumatic incidences, people can become desensitized to this, and actually it becomes a norm. So we've got to have a sort of a duty of care to our staff to make sure they're not actually having that that response, because obviously that's not going to be helpful with it. Whoops, sorry. And then obviously we're looking at, I'll just go back then. We're looking at then a collaborative thing. Sorry, trying to see how I can go back on this computer. And then obviously we're looking at collaborative approach and engaging patients to design services and interventions for the future, but as well linking in with hospitals and navigators and outside agencies for a more seamless journey. And then the last one was the integrated data set sharing, and as well making it more readily available across organisations, and as well supporting trauma-informed practice across the sort of whole system, making this much more seamless. So next, sorry, just that. Next one is that we're looking at childhood aversion trauma. So I'm not going to teach you about adverse childhood experiences, but obviously it's having that understanding and awareness. These experiences are stressful events and can cause significant social, emotional, neurobiological and psychological and behaviour adaptations that actually then people use to survive. So we talk about adversity, but that actually describes a situation and experience. Trauma is the impact it has on the mental health. Okay. So going on to obviously actually what does the impact of ACEs have on young people's lives? So we talk about memories, and traumatic memories can be stored very, very differently. And actually sights, smells, taste, touch, sounds, they become more vivid. You can actually react physically, and it brings back the original emotions, flashbacks. So if one of the adverse childhood events could be a death of a parent, and imagine having that where you then seeing and associating someone, a paramedic in a green uniform or police, with the death of a parent. That when they then get exposed to that again, those sights, those smells, those sounds, the flashing lights, they can actually then have that very physical reaction back with it. And also we're looking then at beliefs. So they can believe if they've been a victim of a traumatic incident, whether it's been a robbery or they've been hurt by someone, that they can think they're vulnerable, and then they can then think they're in danger, and they're unable to relax. And actually, are they actually on the edge most of the time? And as well, you get this maintenance, which then is about the avoidance of not wanting those memories to ever come back. But the more that they do this, the worse it can get, and these memories can then be triggered even more. These individuals can avoid getting or accepting help, and interaction with people in authority is very, very difficult. So actually, when we're going to those incidences and seeing these patients that may have been hurt, may have been stabbed, or may have been attacked, what is actually the impact of us going there is going to have on them? So we really need to have that sort of a lot more of a holistic approach, and actually understanding our own body language, the non-technical skills, our voice, and be able to sort of bring these situations down. Just a quick slide here that just shows that it actually does, not only does it impact you in your sort of early childhood, but all the way through, and can actually lead to increased morbidity, increased problems with alcohol, drugs, and actually there is so much more that as well impacted the mortality. So if we can actually have some impact on these individuals at an early stage and stop this sort of disruption and prevent these sort of ACEs or prevent this, we can have a massive impact. And that led me to thinking, actually, in my practice, I go and treat the alphabet when I go to a stabbing, a shooting. I go and look at my catastrophic hemorrhage. Airway, I can do that. Breathing, fine, can assess the chest. I can actually help that patient physically. Circulation, fine. Disability, exposure environment. We all know what that means. But actually, do we ever think about the psychological impact and what we can do to actually reduce the impact that that incident has had, but also as well, try and pave the pathway for further assistance, so building up trust, respect, and as well, actually allowing the individual to access help. So if we start it in the pre-hospital arena, we follow it on through trauma-informed practice, through the hospital, through the nurses, the doctors, and as well looking at how the sort of navigators, and then actually social prescribing, and then how we can actually sort of reduce that impact and that circle of violence. And actually, I think I would have changed my practice now looking at this. I've just got a short video. So this is one of my colleagues who has an interest in
Hi, I'm
care.
Hamza. I'm a paramedic with the North West Ambulance Service, 2 years at Edge Hill and then 3 years at Central Manchester. Yeah, Central Manchester, big city, so there is going to be quite a few problems with gangs, tit for tat, whether that's guns or knives, but general domestic abuse and all that sort of stuff. Well, in any sort of health and social care sort of courses, whether that's at a school, college or uni, they always do a whole sort of module of communication, and they talk about people with like learning disability. For instance, went to a double stabbing, 2 fellas stabbed at a car wash, bizarre incident, they were all quite static, and you got to talk. One patient was really, really agitated, while the other one was like really shaken. The agitated one was like proper riled up, while the other one a bit more timid. And so it's understanding that you got to talk to one at a level where you've got to calm him down, and you've got to talk to the other one where you've got to reassure him and say, listen, you're okay, you're in safe hands. Whereas the other one, you've got to say, listen, it's happened, let's deal with your injuries now and get you sorted. I myself grew up in quite a rough area back in Sheffield, and the first thing that ever, when you grow up in a rough area, you never trust people in uniform ever, whether that was the police, ambulance, the fire service, you always sort of stay away from them. But that's how we brought up, that's the area, and that's what they've taught us. But as I've got into this role, it's a different environment. We've got to understand when we step into someone else's home, this is where they're being hurt, this is their home, this is their comfort zone, but someone's come and terrorised it. But now we're stepping into it and we're being like, oh, we need to do this, or we need to do that. We're very high, there's a lot of high adrenaline. So like when we're treating these patients, we've got to come down a level and remember that we're in their environment. Yes, we need to make sure the scene's safe and everything like that, but we've got to understand this is their environment, we're stepping into their place. So let's be a bit respectful and yeah, build a trust, talking, using like a bit more relaxed, because at the end of the day, all they see us is people in uniform. They don't know we're like them. We're human beings at the end of the day. We grew up in similar environments, similar struggles, but we've just got to relay that to say, listen, we know where you're coming from. We've come from there as well. So let's meet in the middle. The biggest one is don't judge, don't pre-assume that something's happened. Talk to people with respect, give them a bit of boost of confidence, and respect goes a long way. We've heard it all the time. Give respect earn respect, isn't it? And in this sort of situation, we need to sort of not assume anything, because we've got to understand we're not in this person's shoes. We don't know what's led to this event. So we've got to take a step back and be open-minded and listen to what they have to say, because at the end of the day, it could just be a simple misunderstanding, the wrong place at the wrong time, or just a bad sort of upbringing. Hi, are you okay? What's gone on? Because you seem like you're really upset about what's going on. So yeah, let's not judge. So we'll start with the professional, because we go into these situations quite often, unfortunately, because everything's all driven on adrenaline, so people are going to have high octane. So you've got to look at it there, because we're first and seen, we see a lot of people at the worst time ever, and they're quite vulnerable. And they like to, if we can break that initial barrier and speak to them, they'll open up. And we want to break this vicious cycle of the same thing happening over and over again. And I remember a kid at my school, very, very clever lad. He should have joined the RAF. He was that clever. Towards the end of school, he joined a gang, ended up slashing someone, went to prison. But then I met him a couple of years later at a cricket ground where he was playing football there. And we got chatting, and goes, oh, what's happened? Like, what happened? He goes, oh, I joined a bloody gang in it. That's what's happened. Slashed someone, did me prison sentence. Now I can't get a job anywhere. But I'm trying to change my life around now. So just on that little sort of comment. Well, that's me and him knowing each other from school days. So we found like a common ground, and he's opened up about him going to prison, and it's all happened. Now he regrets it. How many times do we ever hear of patients, oh, I regret doing this now? It's very rare, isn't it? Because once we've had our dealings, that's it. It's the hospital's problem or the police problem. That's it. We've done our bit. But really, we need to sort of have a bit more of a duty of care in the long term. Yes, it's all good with treating people in sort of fast-paced environment. Yes, it's all fast-paced, but as an ambulance service, there's a lot more we can do for patients, like going to schools, having talks, working with communities, mosques, churches, temples. Oh yeah, definitely. Impact is huge. Families, I speak from our sort of perspective, being a Pakistani lad from a Muslim community, we're very close-knit. It is sort of a worry. When we was kids, my mum was always worried that he's off to school, it's a bit of a walk, will he be all right? There's a bit of stabbings going on here and there, there's violence, will he be okay? So your family's always worried. But can you imagine, like, someone's being hurt, they've been stabbed or sort of attacked, and you see the trauma it's inflicted on the mother's always worried, the family are worried. It has an effect on everyone. Being sort of in a community where we're all close-knit, everyone's going to get word of it, and then they're all going to start worrying, and then you can lead on to like, I definitely know if anything sort of happened to me, my mum will be absolutely worried, my uncles and aunties, but then they go into the wider community, everyone else will be worried, and then someone will get riled up, and then it's tit for tat at the end of the day, isn't it?
Yes, so thank you very much. That was Hamza, one of the guys I work with. So I'm going to pass you over to Rachel now, and thank you very much.
Thanks, Kirsten. And just, I'm not where I expected. I'm on Kirsten's slides. Let me just click through. Thank you. And what I wanted to talk about in this section was tell you a little bit about violence reduction units. Some of you may know about the existence of violence reduction units, but for others, you may not be aware that since 2019, the Home Office has funded 18 violence reduction units across the UK. They chose the 18 areas with the highest incidence of violence, and the units are commissioned and given not inconsiderable amounts of money, we're talking about millions of pounds here, to take a public health approach to tackle serious violence and root causes, and I'll talk about a little bit about that shortly. It's perceived, and a growing base of evidence, that there are key drivers of violence. There's adverse childhood experiences that we've referred to already, and a strong link between violence and deprivation, and likely worsened by the austerity that's happened over recent years. So violence reduction units are a multi-agency and multidisciplinary. So I'm part of the Greater Manchester Violence Reduction Unit. I'm the clinical lead, the NHS health lead. I work with colleagues from public health, from police, from education, from probation, from youth justice, from social care, safeguarding, a real host of different professions working together with a single common aim, which is to reduce serious violence. And if I can use an analogy for the public health approach, I think we now all take for granted the fact that we know smoking is bad for you, and it's, in most circumstances, it's fairly socially unacceptable to smoke. You know, if I were to light a cigarette in my office, it would be a major event. But it wasn't always like that. Over the past decades, we've gone from initially people and scientists and doctors working out the scientific link between cigarettes and lung cancer and other respiratory diseases. That was the first step. And then there's been lots of measures taken to change attitudes towards smoking. So public health campaigns, but also laws and legal changes and changes in society and infrastructure to change the prevalence of smoking and the incidence of the illnesses it causes. We want to take that approach to serious violence. So here's a map of where the violence reduction units are. I noticed from the chat that we've got participants today from all across the country and indeed across the world. But I'm hoping that most of you will spot on the map of violence reduction units relatively near to you. And this is a very busy slide, and I'm not expecting you to learn this and memorize it. But it's really talking about the drivers and the context for violence that are complex and overlapping. And you can divide them into both risk factors that make violence more likely, and then factors that protect against violence. There's no single cause and effect, but there are those sort of individual factors in people's lives. So exposure to drugs, alcohol, exposure to violence when they're growing up, exposure to traumatic events such as the death of a parent or the imprisonment of a parent. So they can increase risk of violence. There's by no means a foregone conclusion. Just because somebody's had some difficult experiences growing up doesn't automatically mean they're going to become violent. Because there are also protective factors. So nurturing close relationships, that obviously with parents, but if not with parents, then that can be with other supportive adults, and also with professionals that they encounter, people listening to them, people valuing their input. And then we've got to look at the wider things across society. So looking at the income of the family, looking at poverty, looking at the social context in which people live, exposure to drugs and criminal exploitation. People often talk about gangs when they're talking about serious youth violence. The vast majority of young people involved in gangs are being exploited. It's criminal exploitation. They're vulnerable people being taken advantage of. So yes, they may end up with behaviours that for us as healthcare professionals are challenging to deal with the impact. But if you start changing your mindset to rather than thinking them as bad people, difficult people, start thinking about them as being vulnerable. Start thinking about their life experiences, the way that they've grown up, their prospects, their relationships, and it might help you understand some of the behaviours that you have to face and how to deal with them. So again, public health, my public health colleagues, where an emergency physician likes 3 words, public health colleagues like 300 words. And they always produce these very, very long and detailed documents and very busy slides. But the actual principles are simple. It's still talking about primary prevention, really from early years, trying to get people from their early childhood into good relationships with good opportunities. But then if things do go wrong, making sure we've got the right responsive services, so mental health services, drug and alcohol services. Obviously, as professionals dealing with injuries, if they occur, it's important that we do that, because there's no point in having a public health nurturing trauma-informed approach if you haven't actually stopped the bleeding. So we need to do both, and we need to do them hand in hand. So certainly where I work, I've been talking about this a lot, but actually what was great was last year was some of our junior doctors actually approached me. They'd been put in touch with me because of my role at the VRU, and they came to me and said, what can we do? What can we get involved? So Anna and Joe here. So Anna's working with me to produce a flyer to educate healthcare professionals about county lines and what sort of injuries and presentations people might have if they've been involved in county lines violence. There's some increasing evidence emerging that young people can have deliberately inflicted hand injuries as part of punishments in county lines. So we're doing a little bit of work to look at our data on that and then start educating our colleagues about it. And this is a quote from Joe. I'll just pause for a moment so you can read that, but really just reflecting on what it's like working in A&E, some of the patients that we see and the drivers and the experiences that lead them to be there. So there's another of my colleagues, Matt's one of our F2 doctors, and I'll let him speak for himself.
My name's Matt Dawson. I'm an FY2 in emergency medicine. The reason I care about the violence reduction approach to violence is because it forces us to humanise the person in front of us and see them as part of the context of their lives. You know, what's their childhood experience, what's the chaotic situation in their life that's bringing them back time and time again to the ED. And I think that's important because not only does it mean that we're able to be more empathetic, but it also means that we start thinking about what are the things in this person's life that keeps bringing them back again and again. And if we take an evidence-based approach to try and tackle these issues, we can try and change that person's life so they don't come to the ED, rather than saving them, patching them up, but knowing that they're probably going to come back and potentially come back more injured than they were before. There's loads of exciting work going on at the moment. The simplest thing you can do is just focus on the data and try and find out, how does your ED collect data on violence, and could you be finding more information or better information, because information sharing between services is the first step really to public health. You might even have a violence reduction unit stepping up near you, which is where you have sort of interventions directly targeted at the risk factors for violence, and if you can get involved with evaluating that or helping setting that up, that would be a great thing to do too. And at the very least, try and educate yourself about the public health approach to violence, because it's a sort of changing tide in how we deal with this problem, and we need to start thinking about it as our problem, not just a criminal justice problem.
So just to give you examples of some of the projects that we've been developing with our VRU, but they're by no means novel, and I know many parts of the country already have existing schemes like this. So looking at emergency department and hospital-based violence reduction programs, there's good evidence when you look at people who are seriously injured or killed in violent assaults, to show that many of them have previously attended the emergency department with lower level sort of non-serious injuries, and often people haven't really picked up on those as warning signs. So if you can intervene at an earlier time, and when a young person ends up coming to hospital because they've been assaulted, it may be a stab wound that's non-life threatening. It may be that they've been beaten up and come in with some facial injuries. They come in, and at that point they are vulnerable. You know, they're in pain, they're frightened. They've been separated from their peers and the people that they've been associating with. And it's a really powerful moment in which you can potentially intervene, a teachable moment. If the right person approaches them in the right way to encourage them to stop and think and reflect about where they are, how they've ended up there, what's led them to be there, but more importantly, what they would rather be doing. You know, what opportunities are there for that young person? What could they be doing instead? How could they be supported to move away from their current associates to spend their time and energy in a more useful and constructive, positive way? So we're going to be introducing in Manchester, funded by the VRU, some hospital-based navigators, but a number of places have got some of those already. So I've got some comments from some colleagues, some youth workers who are working in London, and I'll let them introduce themselves.
Hi, my name is Sabrina, and I'm a youth support worker with Oasis Youth Support over at St Thomas's Hospital A&E. Our service offers one-to-one mentoring for young people aged between 12 and 24 who attend as a result of violence and/or aggression. Our service is in response to the rise in serious youth violence both in the Lambeth and Southwark communities. We support young people who have been affected by gang violence in their local areas, and those who've been exploited into criminal activities and sexual exploitation. We also support young people who are struggling with anger management and those who are struggling with their home and school lives. We support young people back into employment, education and training, but also we explore ways of personal development, personal growth, and helping them to build a healthy mindset and perspective to life. One of the main objectives to our service is offering a safe space for young people to explore the issues that are going on in their lives. We offer emotional and practical support and really dig deep into the issues that the young person or young adult may be facing and look at practical steps in ways that we can help support them to a more positive future.
Hi, my name is Dwayne. I'm one of the male youth workers based at St. Thomas's Hospital, and I deal with young people aged 11 to 25 which have been victims of violence in the area of Lambeth and Southwark. So a lot of the cases I deal with, for example, low risk case would be a young person, came through the A&E, punched the wall and ended up having a boxer fracture, which is quite common in our cases. So I worked with that young person to kind of understand why they're punching walls, and I didn't actually find out until 2-3 months into the intervention, after building up a rapport and trust, because that's what it takes for a really good intervention to work, is building up that trust with that young person and understanding what needs and what things they need to help their growth. So work with that young person up to 3 months with confidence and identity, because that was the issue as to why they punched the wall, because they were feeling like they were misunderstood. So we get a lot of those cases where it's about working with that young person holistically, trying to understand what they're going through. A medium risk case would be, for example, young people which are involved in serious violence incidences. They've been stabbed, they've been in a very bad fight. We work with that young person trying to understand what's happened, why they've been stabbed, where they've been stabbed, because the location is very important, because it can cross over into being a high risk case where a young person's been stabbed or shot on their doorstep, and it's a lot more gang affiliated. There's a lot more police involved. There's a lot more risk factors for that young person. Sometimes young people find themselves being around older people, being groomed and being coerced. So it's about kind of identifying that, even from a medium risk case to a high risk case. An example for me would be, a high risk case would be a young person which has been stabbed quite badly, has been shot, and obviously that's going on borderline fatality. In that instance, we try to relocate that young person. We try to involve a lot of other professionals involved to work around that young person, because it's important for that young person to feel safe and feel like they are being safeguarded within that kind of aspect. But a lot of the time, the high-risk cases could be county lines. I've dealt with a lot of county line cases. I've dealt with a lot of cases where young people have been involved in selling drugs and it's gone wrong, or retaliation cases are also classed as medium to high-risk cases too. Thank you.
So I hope that's been interesting and thought-provoking, and I hope that some of you are thinking, what can I do to find out more and get involved? Well, you've already taken the first step, so enormous thanks for joining this session tonight and listening to what people have been saying. If you want to get involved, I think there's lots of things that you can do. I think depending on where you work, first of all, go back to work. So go back to your ambulance service, your ED, your hospital, your trust, and ask what's happening, because there may well be projects that are evolving and developing and that you can get involved in. Matt spoke there about getting data, and it's really important for this public health approach to work that we've really got to understand the data and the problem. And one thing I've been doing over the past 6 months or so, because I work in an emergency department, is really looking in depth at the emergency department data, because when it was shared with me, I looked at it, and as soon as I looked at it, I knew it wasn't right. They showed me the data for 10 hospitals across Greater Manchester, most of which I'd worked in at some point, and I knew that those relative proportions weren't right, and the data recording had some gaps in some places. So we've been doing a lot of work on it, improving data quality. And then the other option is to go to your local violence reduction unit. They're all structured slightly differently, and the amount of direct involvement of frontline healthcare professionals does vary between VRUs, but my feeling is that you can't do public health on its own. You can't just do it looking at data and producing long reports and slide sets. You've got to map that approach and marry it up with people who actually work at the front line, who meet these young people at times of crisis. And so I think there's an enormous strength in combining the public health approach with the experience and knowledge of people who work with these young people and their communities. So go and knock on the door of your local violence reduction unit, and I'll put my contact details up there. So if you want to email me, I've got contacts in most of the VRUs nationally, or can help you find out who to contact. Many of them have got websites, Twitter accounts, etc. You may be able to track them down. But if you're having any difficulty, please drop me a line, and I'm happy to try and support that. So if you want to get involved, I think go and put yourself forward. Start talking about this with your colleagues. Start changing the narrative when you get called to a job. Start thinking about the vulnerability and the challenges of the young people you're dealing with, not just the injuries. And I think if everybody on this webinar tonight and all of their colleagues all started working in this area, that would be an enormous movement from sort of frontline health and NHS to link up with the existing work that's happening with public health. And I think together we can make a